Are you ready? Hello, good morning, or I think it's good morning or good afternoon. My name is Adamika Arthur, and I have the pleasure today to introduce us to this really exciting and wonderful session, specifically around zooming in on racism and equity. And we're going to be talking about all the things telehealth and health equity and tech equity today. I have three tremendously fabulous panelists with us today. And so I'm going to have them each introduce themselves, and I'll go in order. So we'll start with Ray, and then Gil, and then end with Shoshana. Why don't you go ahead and introduce yourself, Ray?
Yeah, well, good morning. Thank you for inviting me to participate in this really important topic. So I'm the Chief Information Officer for Ultimate Health Services here in Los Angeles, California. Ultimate provides essential services to the Latino, multi-ethnic, and the underserved communities in East Los Angeles, Orange County, and across the broader spectrum around there. And we've been a last mile provider in a number of the COVID-19 screenings, as well as vaccinations, as well as promoting wellness in the low income, again, underserved areas where we have a lot of challenges culturally, linguistically, and unfortunately, many of our patients do fall into the digital divide area, and we do see health equity issues as well, and we're fully committed to closing those, and doing the best that we can to better the lives of everybody, independent of their ability to pay, independent of their zip code, independent of their current health status.
Great, Ray. Thanks. Gil?
Thanks for having us here today. My name is Gil Addo. I'm the co-founder and CEO of a company called Rubicon MD. We're a 7-year-old digital health platform on a mission to democratize access to medical expertise. We do that with a suite of services that support primary care clinicians by enabling them to get access to specialty expertise. We support groups across the country. We're a venture-backed business. We've raised a little bit over $40 million to support about 6,000 clinicians across the country to date, with a large population that supports Medicaid patients as well.
Wonderful. And Shoshana?
Hi, thanks for having me. I am Shoshana Brown, CEO and founder of AIR NYC. We are a nonprofit community-based organization based here in New York, working exclusively in the 5 boroughs. Our mission at AIR NYC is to have our community health workers meet people where they live to improve health, connect families to social care, and build health equity at the individual, family, and community level. We ground our interventions in public health principles. We augment everything we do with technology and data analytics, a lot of grit, and a deep commitment to helping people. Our team speaks many of the languages of the people we serve. And again, we work citywide. Through COVID, in the last year, we've worked with over 10,000 patients, connecting people to essential services, including healthcare, including pharmacy access, facilitating all of that through all of the different modalities for people who definitely lack access, not just to care, but to digital connectivity, and to all of the sort of things that we need to be healthy. Appreciate being here with all of you today.
Great. And I'm Adamika Arthur. I run a nonprofit called Health Tech for Medicaid. We essentially bring payers, providers, policymakers, entrepreneurs, investors, and people who are vulnerable in this country, along with their families and advocates, together to scale and innovate in the Medicaid space. So we're really at the intersection of where health equity and tech equity meet. And so I'm really delighted to get the chance to moderate this panel today, not only due to the incredible experts we have, but the very large issues there are. So I'm just going to frame the conversation talking a bit about, despite the kind of promise of digital tech innovation and our efforts to promote health equity through culturally competent digital technology, we are met by systemic biases, misaligned and unrealistic expectations, and health tech's utilization and access to communities of color specifically, but also populations of vulnerable people, as were explained in the description of this session. I think this dichotomy exacerbates kind of the inequities in the patient experience or how people get care, the availability of health data that is available, the disaggregated data sets, and also quality outcomes, how, the quality and duration of individuals' lives. So today we're really going to talk about how do entrepreneurs and communities and cross-sector partners work together to address these intersections, investing in like the promise of better health, with a very big elephant in the room, right, which is racism. And so I'd love to have some conversation a bit about that. And I'd love to start with Gil, because you shook up the industry this summer. Few months into COVID, you're on the ground in New York City where things are really, really bad. And you wrote, you put pen to paper to a letter that really got amplified around the industry and really talked about systemic racism. Can you tell us a little bit about the letter itself, the impetus for writing the letter, and what has happened since then?
Yeah, absolutely. So, we saw obviously through early last year, COVID-19 have a devastating impact on everybody, but disproportionately the most vulnerable, which is largely communities of color. And then leading into the summer, we had the murder of George Floyd, which then, prompted this extended period of what we'll call, racial unrest. And what we, started and people started talking early about, and then it became immediately apparent, I think those aren't different problems. They are the same problem. And we're confronting it every day. And I think, the work that Ray does, as well as the work that Shoshana does, is directly addressing the impacts of systemic racism in these communities. And so we had a couple really open conversations with some other Black healthcare leaders, and we started to facilitate a dialogue. And that was, I think, really great in the immediate aftermath. But I think there was this missing piece of the discussion, which, specific to our space around digital health, was how the pandemic and the shift to virtual care was leaving these same populations behind. So when you look at all of the largest costs of healthcare in this country from a disease perspective, they all disproportionately impact Black and brown people, right? Diabetes, obesity, chronic kidney disease, COPD, now COVID. And so all those costs are wrapped up in the cost for the healthcare system. And so when we shifted to virtual, it wasn't like that closed the gap in access and empowered, it actually exacerbated the problem. And it exacerbated the problem for a few reasons. One was the digital divide. And we talk about it more as the social determinants of telehealth. This is an expansion of, the social determinants of health. But if you're going to engage in a virtual care or telehealth visit, you need to have, Wi-Fi. You need to have a device, but you also need to have secure housing. And so there's a series of things that you need to have to be able to participate virtually in care. And so that was widening the gap because there were a lot of communities where those things don't exist. And so that was the first thing. And I think a lot of people understood that because of what we were seeing in education around the digital divide. But I think there were a couple other pieces. So the second piece, which we spoke about in the letter, was the underinvestment in the clinicians to support the safety net at the time in which you needed, in technology, at the time in which you needed to be investing more. And so Rubicon MD, our core platform, is an e-consult that supports primary care clinicians. And we were seeing, because of a lot of the structural challenges around, Medicaid, which was strained at that system, and, budgets were being cut, a lot of the organizations that were supporting these communities of color were seeing underinvestment and seeing services taken away from them around technology at the time at which they should have been investing. And so to be able to have a telemedicine visit, to just use a simple example, you need the patient and then you need the clinician. If the clinicians aren't enabled and the clinicians that support these communities aren't, then you're not getting the other half of the supply needed to be able to complete the interaction. And so we saw that as the other key problem, is that you needed to be able to invest in these communities and the clinicians that support them. And then the third thing that we flagged through the letter as really important was this challenge around being able to meet the community where they are, to educate them on what they, make them aware. And I think too often as an industry, we've looked and said, if you build it and it makes sense to us, that, they will come and people will use it. I mean, that's just not the case. And so finding ways to directly engage people in the community, make them aware of the services and educate them. And so I thought it was incumbent. I thought I was sat in a unique position to be able to kind of call out folks in our space on this issue and to really start to shine a light on it, because it was going to become even worse, because obviously we've seen the pandemic has lasted a year now already. And telehealth is exploding, and virtual care, whatever you want to call it. And so we need to make sure that it is reaching the people who need it, who are the costs in healthcare right now, and who need the access desperately. And so that's what the impetus was. And I think, it's been heartening, to Health Tech for Medicaid obviously took up the baton and has run with it, and so many others. And it's been heartening to kind of see how folks have responded and the interest and willingness to start to move towards meaningful change.
Yeah, I mean, it's very interesting because we also now see how telehealth is moving the needle forward on how people get access to vaccines. And so if you didn't have telehealth access before, you certainly don't have it today. And if you don't have it today, you now are in what I call vaccine apartheid, right? Like we are really pushing these systems out. You know, Ray, I'm thinking a little bit about, you have deep experience in working in healthcare delivery, right? And Ultimate has a great focus on health equity and serving underserved populations. What is the vehicle for your current efforts as you sit in a CIO seat? And how are you using tech to advance health equity? What are you hoping to accomplish, and what's missing?
Yeah, so it's interesting. I mean, I think the first date of the pandemic was March 10th. And so we're just a year past that, right? And so for health delivery systems, I mean, we serve about 300,000 patients in Los Angeles, Orange County. We went from having in-person visits where you have your trusted relationship with your provider to going to zero. I mean, and people were afraid to come in. A year ago, I didn't have a video platform. We went live with the new EMR system just 6 months before that. And so we had to really fast forward everything that was happening, including figuring out how do we take care of the patients. From the CMS perspective, the reimbursement rates, what would not be, reimbursable. The feds spent quite a bit of time with more traditional hospital systems, and it took quite a bit of time for it to trickle down, to come down to community health centers before we were actually able to act, right, in terms of how this would be accommodated, and if they would be, potentially paid for or not paid for. But putting that public policy side of it, when you look at the technology part of it, I remember talking to my CEO, Coslo de la Rocha, and it was April 8th, and he goes, "Ray, I need a video solution." And I'm sitting there going, okay, I just pushed everybody out to be remote, socially distanced, keep folks safe, and we stood up a video solution really within a week, and we went even longer in terms of doing a more integrated solution with our EMR. We have actually delivered over 80,000 televideo or telephonic type visits in the past year. So it has had some adoption, but there are a lot of challenges. So from a technology perspective, for providers, let's look at it from two perspectives, the provider perspective and the patient perspective. This is a whole new way for doctors and advanced practitioners to interact with a patient. And usually used to being kind of face-to-face, but now they're doing it through a video platform, and there's some protocols that you should follow. There's how do you know when the patient's in the room? How do you not know when the patient's in the room? There's a whole workflow change that happens from an operational perspective. And we put a lot of focus traditionally, right, on how do we help the provider to be successful. And I think to the point, right, on the patient-centric side of it is much of what Gil said about the digital divide. I've talked to many folks that are developing new applications out here that you can't design it for the latest iOS system because the underserved may not have an iPhone 8 even, right? They may have a lower version of it, and they're not going to be able to access this due to a number of the things, Wi-Fi, cellular service, et cetera, or the ability just to pay for those, make those choices of food versus connectivity. So you take it another step further as well, as it has to be culturally acceptable to the patients, right? The language has to be properly translated into it in Spanish or whatnot. And I think a lot of folks out there, they kind of rely on like Google Translate, which really does not take you to the right comprehensible language level, right? When we're communicating to the folks out there, we should really kind of targeting a 3rd to 5th grade level of Spanish so that people can really understand it. But then again, they may or may not be aware of, you click here, or we confuse people because they go into a waiting room, they're not quite sure what has to happen. And so there's a lot of making sure this is easy for the patient so that they're able to adopt it. So to me, it's kind of a continued journey of where we have to get to. But the other part for community health centers is the role that we play is that we are in the community, we are the last mile, we are trusted around there. And, we have to continue to have those outreaches and pushes, to our patients. So example, other things we're doing now is with the COVID-19 vaccination, we're sending out SMS texts to our patient population as we move from the different tier colors so that they can schedule their appointments, right? I've gone past tier 1A and 1B to the more broader community, right? So we can continue to outreach them, and we're determining where in the community we should be placing our vaccination sites beyond our clinics or our pharmacies.
Yeah, I mean, it's so interesting, right? As you talk about like quickly setting things up. Shoshana, you just wrote an incredible piece that, or you were featured in an incredible piece that was written about community health workers and how there should be, right, an emerging re-recognition, right, of the value of the workforce, right? I mean, Ray talks about putting together a video interface, and that's stressful. I mean, as a clinician, and like that's stressful to staff and others. Can you tell us about investment in the workforce, the place where community health center, community health workers work kind of in the trenches, right? Between public health systems, between public hospitals and regular hospitals, between federally qualified health centers. And what is the tech adoption there? How can we better recognize this workforce?
Thanks, Adamika. I really appreciate the opportunity to discuss this. I'm, as you know, very passionate about this workforce, about community health workers. I had a chance many, many years ago to be a community health worker in rural West Africa and Burkina Faso. And that's where I learned really about the value and importance of connecting with people. We all talk about meeting people where they are, but community health workers are on the ground, and community health workers are non-clinical, and community health workers are non-judgmental. Community health workers are of the communities we serve. And so the ideas that Ray and Gil have hit upon in terms of optimizing technology for providers for the clinical setting, or in terms of the sort of policy level, those are all critical and crucial. Gil, Adamika, your leadership on this telehealth equity issue has been nothing short of inspiring. And, it's been such a pleasure to kind of connect with you at this moment in time. Community health workers are, again, like you said, not a new workforce. In places where there aren't enough clinicians, countries are forced to rely on a workforce who can reach hard to reach people, who can provide education, who can facilitate connection. And that was all prior to COVID. That's all pre-technology. Now, with the issues that we're all living with, and we all know well a year into this pandemic, we're seeing that community health workers are absolutely the right workforce to facilitate the connection on so many levels. So when you think about vaccines and the education and information around accessibility, or any of the sort of factors that inform whether or not a person decides and can access a vaccine, community health workers can do that work as an extension of FQHCs, of other healthcare delivery entities, of payers. And we've been doing this work. I've been leading AIR NYC for 11 and a half years now. And we've been working in partnership, in contracts with payers and healthcare delivery systems on the ground. And we can really see that, especially when we can integrate with clinicians, primary care clinicians, specialty clinicians, even the sort of like social services landscape, when we can help people connect with those essential services that they need, and we're able to reduce barriers to all kinds of care, we can improve health outcomes. We can improve vaccination rates. We can make sure people have their essential medications. And that includes when we're, under sort of closure rules and lockdown. I mean, community health workers can get there, where they can be tech enabled, we can manage data. And I think we're starting to have those proof points here in New York and elsewhere in the country, that this workforce should not only be valued and reimbursed and, have opportunities for professional development, career advancement, education, but also reimbursement. And reimbursement at the level where community health workers can be paid a living wage, reinvestment at the level where we are not doing cheap healthcare for poor people, because that's not what community health workers should be doing. That's not what they are doing. And, one of my sort of things that I can get very, very riled up about is when we see people sort of saying, okay, great, let's take this sort of, front desk person and make them a community health worker because I don't know where else to put them. That's not the kind of thing that we want to see if we're going to kind of hope for return on investment, hope for improved outcomes, hope for health equity, and work toward it. So I'm very much, along with some others in the country, a proponent of professionalizing this workforce, investing in them appropriately, and redefining our calculus in terms of return on investment. Right? We don't subject a medication or a certain type of surgery or procedure to the same standards of, but is there a return on that? Can I get to ROI? We need to redefine those things and think about this from a longer term perspective, from a less transactional, more relational, more longitudinal perspective, because we are talking about the health and education of our people, of our children, of our working parents, and our seniors. And so I think this conversation about community health workers really gets to the heart of who we are. And I can keep talking, but I'll stop because probably somebody else wants to get a word in, like you, Adamika. Go for it.
I was just saying, like, if there's no, like, the thing about Zoom is it's not as good for me to snap and clap. Like, in some ways it might be good with my, Baptist upbringing, right? For us not to be in the same room together.
Yeah.
But I think that, there's so much here, right? Ray and Gil, do you want to respond to anything? We also have a really incredible question in the chat specific to community health workers.
I'd love to. I think what Shoshana is talking about, that longitudinal care. So kind of when you're looking at this patient population, they're not going, to the big name brand hospitals. They can go to the community hospitals, or they're going to be going, to Passaic County hospitals for their care. And historically, it's been episodic care where they're pretty sick and they show up in the ED, no fault of their own. That's just how the disease states have propagated. And this longitudinal of care that Shoshana is talking about is, as folks are being, hospitalized, I mean, we're looking to figure out how do we identify them? How do we manage them? How do we have them have a visit? How do we keep them well in the community? Right. And I think part of the part of it makes it easier, or should be where we're moving towards. But then again, we do have some of the other areas like Gil's talking about. But even if we look at more of the chronic disease states, the CHF and or the COPD perspective, right? There are these interesting tools on remote patient monitoring that we're playing with here at UltiMed to keep the patients, healthier at home with a virtual care team kind of watching them, and we're moving that needle. Okay, and we're going into uncharted territory that folks, at Stanford, Memorial Hermann, were in these other, I'll say more of the Medicare Advantage markets where they enjoy those, right? And we need to push that further into the community, but it's extremely provocative for us to be extending this type of care, out to the patients. And it's really a game changer, right? Because over 95% of care is provided in the community, right? And then the shifting role of the hospitals for the more serious illnesses or ortho type procedures is where we're shifting. So we have to keep folks well in the community. And even more so, like Shoshana's talking about the social determinants of health, also Gil spoke about that. And she kind of talked about the MA, and folks are very proud. And when you have a young MA, right, kind of asking somebody about food insecurities, housing insecurities, and you have very proud people, or you have seniors that are really embarrassed to identify that they don't have access to a refrigerator, right? So they can't have, milk and fresh water. So we have to give them, powdered milk so that they can, have these things, or for mom. It's a really interesting, inflection point. I'm sure that my fellow panelists have some thoughts about that.
Yeah, well, I will say, I think these are the problems that we should be speaking about. And I think the way, and this is part of, even where we're moving with Rubicon MD, to provide longitudinal support and help with those relationships is the way that you keep people from utilizing the ED for care. And that's, if there's one thing that, COVID has helped with, it's people, feeling less comfortable doing that. But you have to have primary care and you have to have great community relationships to be able to avoid that. And, Shoshana has taught me a lot through, the last, few months as we've been working together around this workforce. And I think one of the components of it, if you start to bring it back to, thinking about health and race together, like to be able to keep people from getting into where they're going to the ED, you have to have that relationship and you have to support them. And to do that, you need, as Ray, you said, you need somebody who's in the community who will be able to build that bridge and have that relationship and speak to them and communicate and collect important information and help to coach them along the way. And if you take that workforce that connects with these folks, usually that connection is because they have shared experience and they're of the community, and they're probably of the community because they're of color. And you don't give those folks living wages and you don't give them the support and the services you need, then we're reinforcing the same challenges of surround systemic racism. And so it becomes this cycle where we actually create problems that we then wonder how they ended up with people in the ED. So I think that it just starts with us grounding and respecting there. And I've learned, this isn't, where we've played, but understanding the role that these other members of the care team and what we're, doing around Rubicon MD is trying to build them into the integrated services that we help primary care with, because it's not just the clinician. There are all these other people that participate.
Right.
Yeah, and it is an economic driver. No, go ahead, Ray. But I was just going to say, like, health is the largest economic driver that we have in this country, right? Yeah. So there is an imperative to keep folks healthy, and it doesn't. I mean, we could break down all the systemic racism, institutional racism, societal racism challenges as to why we keep getting ourselves stuck in this cycle, right? Where we're not really treating people because we're not giving them access to be treated. And then we're complaining that they can't contribute to society because they're sick. And then we have to help pay for their care. And then we don't want to give anyone else any living wages to help them as they're sick to get better. Like it is a cycle. Go ahead, Ray.
Yeah, I was just going to, accent Gil's point. It's really about culturally sensitive care, right? The way that you talk to Latinos in different parts, Mexico, Central America, the language of words, they mean different things in different cultures, right? There's a lot of distrust from historical, of the government, doing tests on people of color without their knowledge, right? So we have to break through those barriers, as well. And I think the other part that we all have to play is broader in the community, and educating our patients, right, on their ability that they need to vote, right? And we did a huge outreach on Mi Vota, Mi Salud, right, where we had over 1 million people in East Los Angeles vote that never voted before, right? So they can, actually have a voice in the politics of what's happening. So it's a real fundamental shift. I know we're here to talk about healthcare, but it all kind of wraps, some of it together from a policy perspective and other areas.
I mean, health is like so much more than health. Like it's your
Yes.
ability to contribute to society. And that's why when we talk about health equity, it spans beyond what people think of as health, which is health care, right? I just want to throw in some questions that are coming from the chat just because I feel like that's part of the reason why we're here. How can the fragmented healthcare system that we currently operate in value the vital contributions of community health workers when often there's an elitist perspective that community health workers are inferior to the formal training of clinicians?
I'll jump on that. And I think it dovetails into what I would kind of ask as a call to action to our provider and our clinical partners. I think part of that change is brought about when clinicians recognize the value of what the community health worker brings into the mix. Clinicians are well aware, they were aware before COVID that care doesn't stop in the clinical setting, that when the patient walks out of the room, that's when really the implementation of a care plan starts. And clinicians know that they can't do that on their own, that they don't have that reach. And I think I've seen a shift in the years that I've been doing this work into more appreciation for what community health workers do. And it's often the provider partners of ours who are advocating for this workforce now and who are asking the community health workers to do case reviews and to work together to address the full picture of the full person's life. And that's, if it's a child referred to us for asthma, we have to address the needs, priorities, preferences of the adult caregivers of that child, or what else is going on in the household. That's too much for any clinician. And so we know we have to work together. And again, I'm heartened to see the change. I think where we have work to do is really on the payment model side. So payers, many of them, are starting to have these conversations. Some are further along than others in terms of Medicaid managed care. We have a few partners here, including Health First in New York City, which is a large Medicaid provider here, who is trying to work with us and innovate around these issues. But, I hear often, and I know you do, Adamika, that the healthcare dollar can't be stretched to solve all of society's problems, and we get that, we understand that, and I think other sectors need to come into this. We need to work and braid funding and be creative and resourceful about how we fund this work.
One thing
you guys
that
have heard, yeah, go ahead, Gil.
Well, I was just gonna say on the payment side, I think when we first started, last year, really around this work around telehealth equity, we started to peel back all the layers of the problem. And when you really got to the core of it, it's a payment problem, right? That's so much of healthcare, even when we think about what we do with Rubicon MD, it's a business model innovation to ensure that you're aligning incentives so that primary care gets support from specialists who want to support. So I think that's like at the core of this thing is that, as long as organizations are, forced to just think about fee for service and the reimbursement rates aren't there for certain services, it creates and perpetuates the hamster wheel. Folks have heard me say this, but there was an organization that we were supporting, and one of the clinicians who's a dear friend, told me a couple months ago that they were being pushed and encouraged to stop doing telehealth visits and to move to in-person because the reimbursement for phone calls and the reimbursement for other services wasn't there. And these are folks in the community looking and very engaged and willing to do great work to extend and reach the patients. And that is scary because those are the patient lives that are at risk, and those are the clinicians' lives that are being put at risk. So I think when you start to peel back the layers, as Shoshana alluded to, I think it's the payment reform and the ability to move groups to value-based care and the ability to create these appropriate bundles from a policy perspective is like really at the core of how you solve this.
Yeah, and I think I couldn't agree more. I mean, I think we have a ways to go with policymakers, and Ray, you kind of made that connection to how policy and politics play into this. But I also feel like this is a tri-sector challenge, right? And we have a good example of that here. That that is really how can philanthropy play a part? How does the public sector play a part? And then how does the private sector play a part? And how can we leverage resources between each other really to get there? So before we get to solutions, I'm going to ask one more question that came in through the Q&A, and then we're going to just wrap up with some solutions, some things that you can challenge the audience with, and give us some food for thought. So I guess in setting this up, because it's a big question, I'm going to set it up by saying, how do we understand the linkages, right? How do we get into the specifics of how venture capital, investments, policy, healthcare delivery intersect in the lens of kind of data, digital health, and health equity, with racism sitting right smack in the middle. So what data is the best for understanding how people access services, right? And then what metrics should we be thinking about for health providers to look to improve? And I will say all day long before you guys jump into these questions, because I think it's a little challenging, that we're still trying to determine that business case for health equity. Like, I rely on folks like the folks on this panel to help us figure that out. But take a stab at what sort of data is best for understanding people's access to services, and what metrics should we not forget about in improving health that providers need to think about?
I can jump in on that one, and definitely make time for my colleagues as well. So I think, there are the obvious metrics that in our sector, in healthcare, we all know and look to. It's reduction in expensive and avoidable and traumatic admissions. It's reduction in length of stay for somebody. It's reduction in ED use that can be avoided. And I think, there's a lot of alignment around value-based care. What I would challenge and invite us all to do is think about all of this from the person's perspective. And notice I'm not saying the patient, because we're people before we're patients. And I think that the pathologizing of the Medicaid population is a problem. I think that the lack of voice of Medicaid beneficiaries in developing these solutions is a problem. So we need to think about how do we bring in the voice of the people we're trying to reach, and ask them, what is needed in order to seek better health, in order to be healthier, because that's really missing. When companies, when marketers are testing a product, there's a lot of focus grouping, there's a lot of input, there's a lot of soliciting of the preferences of the buyer. We don't think of beneficiaries as consumers in the way that we should. And I think that until we do that, we're going to keep sort of prescribing these solutions from on high, sometimes from a very kind of authentic place as medical providers and medical people who are used to prescribing. But we can't keep doing the same thing, because that's the definition of insanity. So I think, in philanthropy, we're starting to see as we did on a big proposal that we worked on together recently, we're starting to see foundations and philanthropists, really require grantees to say, well, how are you incorporating the voices of the people in the solutions that you are proposing? And I think we need that from the industry as well. And we need that from investors, because there's a lot of money going into healthcare right now from venture, from other places, and a lot of great innovation and disruption happening. We need to see some of that investment connected to people on the ground. I'll leave it at that.
Yes, but remember that venture investment is expected to give a 10x return on the other side. So
Yes, indeed.
I won't set Gil up for.
I'll let Gil close. So I'll just add a few statistics, right? So there's about 25.6 million people with limited English proficiencies, and there was a recent study in Health Affairs, the March issue that just came out, and honestly, there's like for folks with limited English ability, like 4.8% versus 12.3% of Caucasian folks really utilize telehealth. So you have a 3-in-1 opportunity. That's not a call to action as to why folks should be interested in what's happening, in terms of the opportunity, right? So that's just plain numbers and why we have to make it better. Again, we look at telehealth, and I'm going to take it kind of from a technical healthcare tech perspective. As I've talked to many CIOs across the country, currently we're going up to 60%, right, in terms of adoption of telehealth broadly, independent of market, right? And we're thinking that we normalize somewhere around 15 to 20, maybe some of the intermediary care areas that may continue. Going back to reimbursement, I mean, there is, the CMS switch on July 1st that says that telephonic calls will no longer be reimbursed. And, that may limit, Gil gave the provider example, that may limit folks.
Well, it's not may limit, it will limit.
It will limit, right?
Let's just be really clear.
Thank you. Okay, I'm being kind, you're being direct. Okay, so, when you look at these things here as a health delivery system and you pivoted, a year ago, we did nothing, everything was in person. A year later, we have now done over 80,000 virtual visits in there. And now with the policy shifts, we're going to change that. And, and the consumer or the people, to Shoshana's point, are just going to get confused. They say, what do you want me to do? How do I get my care? Right. And then again, we think about the most vulnerable folks, right? Those frontline essential workers, and, they have to take a day off. They may have a hostile employer, right? They may have a sick kid. It's no fault of their own, it's life, and we're removing that ability potentially for them to access care in a convenient manner. And just because you are low income, and again, many of our folks are 200% below the poverty level, living in multi-generational homes, maybe in a garage, it doesn't mean you should not have good quality access to healthcare. And that goes to the value equation that Shoshana brought up.
Agreed. Gail, do you want to jump in?
I don't know that I have a ton to say otherwise here. I think I'll share the perspective from spending a lot of time with the venture community. And, we have a board and, a lot of those folks that we work with. I think there's an acknowledgement and a very clear interest in being able to start to fund businesses that approach and start to address health inequities. Whether how real that becomes over time and the impact that has still remains to be seen, but there's definitely a willingness and an interest, and a lot of the prominent VCs are starting to at least market businesses that they believe address that. So I think that's a positive. I think the way in which you do this, I'm a firm believer that you can do really, really good work and build equity in businesses that are for profit. And so I think that people are making money, to Ray's point, people make a lot of money off of these populations. There's a way for it to be done in the right way. And I think it's about showing that, connecting the dots with kind of where I started, that these are the conditions that, if left untreated and unmanaged, lead to people in the ER, crashing into dialysis, with multi-chronic conditions that then become costs that somebody says, you know what, I can manage this better and I can, do all these things and put all these services. Well, if we started and did it better early on, you wouldn't have these downstream effects. So I think there's a way to do both. And I think it starts with showing that you can build in a structure of services that helps to manage these patients that leads to a downstream reduction in cost. And I think that is, if you do this really well and you do things in a way that is supportive of people, you will see that. And if you see that, then that is the ROI on which you can build really, really large and important and lasting businesses. So I think there's a way to engage the venture community. I think they're interested and willing. It still remains to be seen on how impactful the dollars from the venture side become in addressing this problem over time. But I think we're certainly seeing people more interested than we have historically. And I think there's a way to do it. Absolutely.
All right, I'm going to give you guys final last thoughts, but I am going to, I think they don't call me the irritant and the accelerator in healthcare for a reason. This is life or death, right? Like access to telephonic care, or health, as I call it, not, it's life or death. We are literally willing, to gamble on people's lives. Those people typically look like, some of us on this panel here, right? This is our communities. And, you're right, Gil. This is, Medicaid itself is a $650 billion industry. It's huge, right? How do we think about reinvesting those dollars into community health workers or in other ways in which we can help extend people's lives, and the economic argument that if people are healthy, they can contribute to society. So I'm going to get off my soapbox for a second and give you guys some minutes to just do a quick lightning round takeaway. What can audience members do today to make a meaningful difference in digital health equity, and how can we facilitate that? Just what could they do?
I'll start. So I'll just say, this last year has been extremely disruptive in healthcare IT, and it's actually changed the delivery model, right? So I have a really simple ask, folks. If you have not adopted any of these new technologies, if you've not done a televisit, if you have not helped somebody understand it, I mean, it's easy if you try one, do and teach one, right? Let's help everybody get there together. And we need to be, again, sensitive to our patient population so they understand it, right? Let's take a moment to think, put ourselves in their shoes. Let's try it out, right? And then we can speak more broadly about it, and we can make it go even further, and again, improve the overall value and quality of our outcomes.
Great. Who's next?
I'll throw out something to the young people who are thinking about careers and are thinking about your interests and how to combine them. I went to public health graduate school. I went to business school. When I was in business school, it seemed crazy that I would combine those two things. Now that's not so crazy anymore. And I can't act like I had, the vision to know that we would be in this pandemic, but I would invite you all to help build our public health infrastructure. And whether you do that from a business-minded perspective or a public service perspective, or look at any of the other root causes of how we got to the way that this country reacted to and sort of failed to handle the crisis that we saw unfold this year. Work on these problems with us. Use your talents. And it's not, you can do it again and also make money. Harness your talents and help us rebuild this country.
Ooh, I need my tambourine, right? Gil?
I'm gonna just have a broader call. It's not individual, but I just think that right now we're in a place where there needs to be, as we're trying to get past this pandemic, there needs to be a continued, I think, focus, pressure, attention to equity, and making sure that we don't lose sight. Once we get past this, we're past that. Don't need to worry about health equity anymore. Don't need to worry about disparities in rate and systemic racism. That was, summer of 2020 problem. We're in 2021 and we've got, other things to deal with, and we've got a lot of other things, and they all, come together. There's problems with climate, there's problems everywhere, but I think I would call on people to just, remember that those problems that led to all the challenges through this pandemic are still there. They will continue to be there. They may not be as front and center. They will reemerge the next time we have any pandemic or crisis if we don't fix them. And so not losing sight of that energy and that focus and that interest in solving the problems that we've spoken about today. So that would be my call. And if people can go out and get vaccinated.
Yep, that's it. I was going to say, get vaccinated, and you can go to the Health Tech for Medicaid website and specifically yourself contribute to a campaign specific to telehealth equity.
Help somebody else get vaccinated. That's
help somebody. Help the entire community get vaccinated. Take the RAISE approach. Have you gotten vaccinated? If so, here's how you get vaccinated. Have you seen your clinician? Right? Have your kids gotten vaccinated for their regular well vaccines? Have you gotten checked in the last year? Did you, hold off your mammogram like everybody else had to, or your colonoscopy? And how can we get you back into care? Could not agree with you more.
Help somebody get connected.
Help your neighbors,
Yeah.
right?
So I know Shoshana and Gil are doing incredible work on telehealth equity, specifically in New York. We can also connect you with that group. But Health Tech for Medicaid does have a very large telehealth equity campaign. And Ray, your esteemed leader, Castello's on the executive team there. So that's probably it. Thank you for coming today. I know we didn't solve all the world's problems, but at least we gave you some tangible takeaways and had incredible thoughts from these wonderful leaders. I'm just pleased to even be in your orbit. Thanks so much.
Thanks, Adamika.
Thanks. Take care.
Right.